Obesity and cancer are not distributed evenly across society. They strike harder and earlier in low-income communities, not because of personal failure, but because of structural, economic, and environmental forces that make health nearly impossible to maintain. The link between poverty, obesity, and cancer is not just correlation, it is causation, driven by systemic neglect that continues to widen the gap between the privileged and the vulnerable. In many low-income neighborhoods, access to healthy food is a daily struggle. These communities are often defined as food deserts, areas with limited or no access to fresh fruits, vegetables, whole grains, or unprocessed meats. Instead, convenience stores, fast food outlets, and gas station snacks dominate the food landscape. Calorie-dense, ultra-processed foods are not only more available, they're more affordable, aggressively marketed, and often the only viable option for families on tight budgets. This diet, rich in sugar, salt, and fat, directly fuels obesity, and with it, the biological changes that lead to cancer, chronic inflammation, insulin resistance, and hormonal imbalance. Physical activity, another cornerstone of cancer prevention, is also harder to achieve in impoverished areas. Public parks may be unsafe, underfunded, or non-existent. Gym memberships are unaffordable luxuries, and urban design often leaves no sidewalks, no bike lanes, and no clean air. Working multiple jobs or dealing with unstable housing doesn't leave time or energy for exercise. For many, survival comes first, exercise last. Then there's the healthcare system, which often fails low-income individuals at every stage of prevention. Regular screenings for breast, colon, cervical, or skin cancer may be delayed or skipped altogether due to cost, lack of transportation, or gaps in insurance coverage. When symptoms do arise, care is often delayed, rushed, or dismissed. Early-stage cancers that could have been treated are missed, and by the time patients receive a diagnosis, the disease has advanced, and the options have narrowed. Even basic obesity treatment is largely inaccessible. Nutritional counseling, obesity medicine, and weight management programs are rarely covered by Medicaid or low-cost insurance plans. Preventive care visits may be rushed, and many providers don't have the time, training, or resources to offer comprehensive guidance. Language barriers, distrust in the medical system, and past experiences of discrimination only make matters worse, especially for communities of color, who are overrepresented in low-income populations and already suffer disproportionately from both obesity and cancer. Education also plays a critical role. Many low-income individuals lack access to accurate, culturally relevant health information. Misinformation about weight, diet, cancer risk, and preventive care spreads more easily in areas underserved by public health outreach. School systems in impoverished districts often offer poor nutritional education, if any at all, and may serve students low-quality meals that reinforce unhealthy patterns from a young age. The result is a tragic cycle. Poverty breeds obesity, obesity fuels cancer, and cancer devastates communities already struggling with economic and social hardship. And because many public health efforts ignore or minimize these structural realities, the gap only grows wider. Campaigns that tell people to eat healthier or exercise more without addressing the realities of their environment are not just ineffective, they are insulting. This is not a problem of individual willpower or lack of awareness. It is the predictable outcome of policies that allow food deserts to persist, that fund medicine more than prevention, that tolerate unequal healthcare access, and that systematically deprive millions of the basic conditions required for health. If we are serious about reducing cancer risk, then obesity prevention must include bold socioeconomic reform. That means investing in affordable housing, universal healthcare, food assistance programs that prioritize fresh produce, safe recreational spaces, school meals designed for health, not budget, and community-specific outreach that gives people real, practical tools to take control of their health. Until then, cancer will continue to be both a biological and social disease, fueled not just by mutated cells, but by decades of inequality. And the people paying the highest price will be those who have the least power to fight back.